Hi, nuclear cardiology, how it is helpful in diagnosis, prognosis and guidance of therapy in patients of coronary artery disease. I will go first for the nuclear cardiology, how it is helpful for diagnosis or detection of coronary artery disease. Suppose a patient having strong family history of hyperlipidemia or history of smoking or a long-standing diabetes mellitus or a long-standing hypertension, especially uncontrolled hypertension, what type of test he or she should do? He or she should do a nuclear cardiac imaging along with a treadmill stress test which would diagnose the silent without any symptom underlying coronary artery disease. After detecting the coronary artery disease on a nuclear perfusion scan, how you detect? You will find a perfusion defect. That area will not get radioactive material and that area will again fill up with the radioactive material. That is called a coronary artery disease detection. So in that case, if the area of the myocardium or heart muscle is small, then it can be treated medically. If that area of the cardiac muscle, if it is medium or bigger, yes, of course, that need treatment. What type of treatment? Treatment is a medical treatment or a angioplasty treatment or a bypass surgery treatment. So, if the size area is big and the patient has got symptoms like what? Shortness of breath, chest pain and breathlessness, then patient should go for immediate treatment. It means go for a angiography and depending on the angiography lesion, then go for a bypass surgery or a angioplasty and patient would definitely come back to normal. If suppose the patient had an infarct means heart attack, and the patient has come for a nuclear cardiac imaging. There what you will see? You will find the myocardium already infarct which has occurred, already it is a dead tissue or a live tissue. If it is a dead tissue, then you cannot go for revascularization or angioplasty or bypass procedure because the tissue is already dead. So at that time what the patient will do? Patient will either to be treated by medical treatment or no surgical treatment, no angioplasty is recommended because the dead muscle cannot be recovered even if you establish the circulation, put a graft, LAD, Lima, RIMA, so that will not help the patient. Or cardiac transplantation. But in India, on the present day context, cardiac transplantation is very expensive because donor heart, the person who will donate the heart is very less and it is expensive. And about the success rate, success is around hardly 20-30 and that will be rejection, an expensive test. So better to go for a medical treatment in the lifelong. Then another subset of patients, patient has done a treadmill stress test, patient has done a MRI or a CT scan. So they cannot localize the disease or the disease is there or not. So in that case what we'll do? If a stress test is positive, we do a SPECT myocardial perfusion scan. If SPECT myocardial perfusion scan comes negative, but means there is no perfusion defect. So because our nuclear imaging sensitivity and specificity is more than 89 to 90%, that is why the treadmill stress test has got a sensitivity of 65 to 67%. So less sensitive, it cannot diagnose, but our SPECT myocardial perfusion diagnose ki look, this is not a normal stress test, this is abnormal myocardial perfusion scan. Again, if it is a big lesion or a medium sized lesion, then one can go for angiography followed by angioplasty or bypass. So this is the way. Then the third subset of patients is when a patient suspicion of atheromatous plaque. What is plaque? There is a coronary calcium which gets deposited in the coronary arteries, and that gets infected and a plaque is formed. So plaque is of two types. One is called unstable, another is stable plaque. So unstable plaque can be detected by CTA, coronary angiography CTA, but stable plaque can be detected, but unstable plaque cannot be detected so minutely by CT scan, because our radioisotope which you give, sodium fluoride, it binds to the calcified area. That's called microcalcification. So microcalcification is beyond the reach of CT angiography. So we detect the atheromatous plaque. So what is the difference between atheromatous and stable and unstable plaque? Stable and unstable plaque. Stable plaque fixates into the coronary arteries very good, and there is very less chance of rupture from the coronary artery lumen and produce the cardiac event. But unstable plaque is a loosely plaque. It can be broken, it can dislodge and goes and blocks a coronary artery and produce a massive infarct. So we have to diagnose, and our nuclear medicine method like F18 sodium chloride, gallium 67 dotatate, these are the agent which you inject. It does not have any side effects. It can goes and detect, look, this is a atheromatous plaque which can be broken or which can dislodge at any time. So what the surgeon or cardiologist will do, he will give intensive anticholesteremic agent like atorvastatin or rosuvastatin in high dose, so that what is the role? It will stabilize the non-atheromatous plaque or unstable plaque to the arteries, so that it will not dislodge and produce the myocardial infarction. This is another area where. Third area is that any patients having an infarct, having a old infarct, and the patient has been referred to us, and the ejection fraction pumping is very less, 30-35%. So in that case, we have to find out whether the muscle is viable or non-viable. So we do a resting perfusion scan on one day. Next day we do a F18 FDG viability scan. Then if you find a mismatch, perfusion defect and the FDG uptake, that is called viable hibernating ischemic myocardia. But perfusion scan, there is abnormality, but viability means there is abnormality. That is called match pattern. That is called infarcted scar dead myocardium. So this is called the gold standard in the assessment of myocardial viability using F18 FDG. Apart from this, it can also detect inflammation, chronic inflammation, or inflammation following the cardiac device things which you can put, that can be detected, and the treatment can be given. Anywhere, any infection like streptococcus, other infection, it can be detected and we can start the treatment. So nuclear medicine nuclear cardiology has a very big role in the diagnosis of coronary disease, in the treatment planning which I discussed, and also the detection of atheromatous plaque, and also the detection of the infection process, and monitor the infection process after getting the treatment. So it has got a huge big role. So with this I end my lecture, and thank you very much for giving me an opportunity. Thank you.